Good afternoon. I've used a lot of pink slides because this is the theme. So if you're overwhelmed, just forgive me. Right. So dyslipidemia and gender disparities or differences in the MENA region. And I'm just thinking this is unmasking a silent cardiometabolic crisis in women. It's a hidden epidemic. In 2023, Dr. Wa'il Mohammed and Dr. Mena have published in the Lancet, the CVD is the leading cause of death among women globally and in the MENA region. Women present later with atypical symptoms, but we did mention we do present with typical symptoms, but when we present with other symptoms, it's ignored, which leads to misdiagnosis. There's cultural stigma and limited access and low health literacy delay prevention, especially in treating dyslipidemia. Modifiable risk factors like dyslipidemia go untreated. And you could look at the diagram there, the pandemic of coronary heart disease in the MENA region. So younger age at presentation, so men and women present earlier. Women even present even earlier, worse prognosis in women because it's delayed action from the healthcare system or delayed recognition. Gaps in coronary heart disease prevention, limited access to cardiac rehabilitation, under-recognized, undertreated, uncontrolled metabolic risk factors, and underutilization of EMS and primary PCI. Lack of public awareness of coronary heart disease, need for regional guidelines and registry. So the silent presentation that you've, so some of the slides are maybe a repetition, but they're non-classical symptoms. I've borrowed this from the Canadian Women's Heart Health Center. It says, when in doubt, check it out, which I really like. So there are some, if someone presents with fatigue, tiredness, and you think they are a high-risk profile, I think you need to investigate further or send them to Dr. Dima to look at microvascular disease. So, and you hear these stories, especially with the perimenopausal, time, and even sometimes, now I have a patient, I might discuss it later, her husband passed away, and she's been complaining of shortness of breath. She's very high risk, and I think she has microvascular disease. That's causing it. She said she had a stress test. It was normal, which I doubt. She had a WBC, it's normal, which I doubt. So I think she really has some disease. She's not pretending. It's not an anxiety or a panic attack. So there are some challenges, diagnostic and screening challenges, interventions, heart failure management. We know that women present with HFpEF more than men. And as we mentioned, underdiagnosis in women with conventional tools, using stress echo, CT angiography, cardiac MRI. I thought it was really interesting, Dr. Rosen mentioning about the mammography. I think, can it be a surrogate for, well, it can't be a surrogate for calcium scoring, but maybe we can use it as a calculator of risk, possibly, and then use of NT-proBNP. So hormonal endocrine contributors, which we already mentioned, and I think just repeating what Dr. Adima said already, I'm thinking that we should look into HRT replacement therapy, and I think the delay in treatment in women is not just the way they present, it's also the fact that they're in childbearing age. So should we really treat them when they're in childbearing age? They're married, they want to have kids, so we delay the treatment of, say, statin therapy, hypertension. She's mildly hypertensive, we're not going to start. So I think this is where we're saying, oh no, the child is really important because it's a cultural thing. That's what I'm thinking. And then also, when we are, say, if they are on OCP, or they're, they have hypothyroidism, we might be thinking that, oh, this dyslipidemia is due to this. So once we correct the hypothyroidism, and maybe when they're off their OCP, we should treat their dyslipidemia. I think this is what our conversation is happening. And they're like, oh, yeah, okay, Yani, come back later. Let's check it off this. And I think that is where we are, there's this gap that we're like, okay, no, she wants to get pregnant, we can wait, and then she's hypothyroid, so let's get the metabolic profile right, then we will see if really she's at a risk of cardiovascular disease. So gender-specific cardiovascular risk factors, as you mentioned, the menopause, PCOS, but I want to mention PCOS has a criteria. So I think more what we have in our region is actually insulin resistance rather than PCOS, and there's a spectrum. So insulin resistance needs to be looked at, and probably this is the main cause. Maybe as well, in women, we have more insulin resistance. And when you mentioned, I think, Dr. Dima, about the blood pressure should be on the lower side for women, I think it's also related to this metabolic profile that women have, probably. So, and then women are more likely to get autoimmune disease, so rheumatoid arthritis and SLE. And there's psychosocial stresses, caregiving roles, and she's the mother, she's the sister, she's the daughter, she does all these things. So, and going back to more of them have central obesity and lower HDL. And this is a busy slide, but I think Dr. Dima again mentioned some of the stuff, but what I could say, that dyslipidemia among women has the highest PR at 47% compared with other known risk factors of cardiovascular disease. And atheromeal regression and LDL lowering may be of greater benefit here. The only problem is that when we give statins, they get more myopathy, more side effects, and we don't start them early on statin therapy. Dyslipidemia trends in Mena women, high metabolic syndrome prevalence, as we mentioned, 50 to 60% in UAE and Egypt, sedentary lifestyle, poor nutrition, sugary diets are common, health literacy on lipids alarmingly low. Not many people know about the importance of dyslipidemia. I like to call it atherosclerosis. So LDL that is increased is more like it's a marker for atherosclerosis. That's how I explain it to the patients, because they think when I say hyperlipidemia or cholesterol, it's like it's food. Doctora, I will stop eating fatty food. I will cut this out. Can I take olive oil? I said, no, this is only 15%. Don't think of it this is just a marker of what's happening inside your arteries. And really in the CKM clinic, what we do is that we just do early detection. So we try to screen. So doing carotid Dopplers, looking at the intimal thickening and the plaques, it's really important. It gives you this visualization and know their true risk to know if they're gonna, they already have cardiovascular disease and what their LDL targets should be. So over 40% of dyslipidemic women are undertreated or undiagnosed. Unique risk factors in Mena women. So this is a study done in Saudi Arabia. We have the traditional risk factors as hypertension, diabetes, obesity, dyslipidemia, but specific to this region is high metabolic syndrome, consanguinity, low physical activity, and vitamin D deficiency. I'm thinking the low physical activity, maybe that's a predisposition for HFpEF. Why do women get more HFpEF compared to men? And by the way, the Saudi study showed more heart failure, increased heart failure rates in women compared to our counterparts in the Western region. Landmark studies, as you know, the CEPHEUS and PURE study. PURE study has gone up to 245,000, but I'm just mentioning one of them that has been, so Mena region showed highest rates of untreated dyslipidemia, gender gap in treatment consistent across urban and rural areas. So there's association of glycemic index and glycemic load with the risk of type 2 diabetes. And lipid markers and depression are more strongly associated with the risk of cardiovascular disease in men than in women, whereas diet is more strongly associated with the risk of cardiovascular disease in women than in men. Similar associations of other risk factors with cardiovascular disease in women and men emphasize the importance of similar strategy for prevention of cardiovascular disease in men and women. So the centralized pan-Middle East survey on the under-treatment of hypercholesterolemia, which is only for 5,000 patients, showed that across 6 countries that 32% of high-risk patients reached LDL targets. Women fared worse because there was actually poor physician engagement. Again, this is the same process, oh, she's going to get pregnant. I think that's what's going in our mind, that she's childbearing age, we shouldn't start the treatment, we'll come back later, do diet, and so on. So the Gulf FH registry and the WHO STEPS insights, if you know that only, can you imagine that in the Gulf, or Dr. Hani probably could mention that as well, Gulf FH registry, only 1 in 7 cases were diagnosed, and women were less likely to actually be referred, or either for genetic screening or even for statins. And the WHO STEPS it was Jordan, UAE, and Egypt, up to 50% women have dyslipidemia, low awareness, and poor statin uptake in women. I wanted to mention mental health because there was a mention, I'm glad that someone mentioned mental health and psychological factors. So stress and anxiety, depression, increase CVD risk. So you have the mental stress, induced myocardial ischemia, when Dr. Dima mentioned that, they get stressed, you look at their corneas, they look normal, so what's going on? Mental health screening and community support are really essential. I was thinking of power of primary prevention. It's a busy slide, but we need to look at guideline-directed medical therapy. It's not being really utilized or used or acted on for women. And probably we need a ASVD risk calculator that is modified to women, say if they had any issues with their infertility and so on. I think this is a good forum to discuss that. Now, case study, the Cardiometabolic Renal Clinic Spotlight. We had a 52-year-old. Now, I did not put her parity, but she had 4. I should now, it's a lesson learned. We should do that. So she had no miscarriages. She had 4 children. I remember her. And she was perimenopausal. She has history of gestational diabetes, central obesity. She felt really tired and short of breath. BMI is 33. Now she's Emirati, so 33 is still high because we should really use 27 as our BMI of cutoff for obesity. Blood pressure elevated, as you mentioned, and pre-diabetic, and LDL 3.8. We did an echo, and we didn't mention this, but she had a 20% carotid plaque stenosis on her right side. She had an echo which showed an EF of 60%, NT-proBNP was 300. It showed grade 2 diastolic dysfunction, and which is a diagnosis of, there are other, of course, parameters and she actually had sleep apnea, so that actually contributed to her HFpEF. Now, this is off-label. At that time, we did start her on GLP-1, and then, of course, tirzepatide is now licensed for her HFpEF treatment. So 6 months later, you see that the LDL, we also added inclisiran because she wasn't reaching her target, and she's achieved weight loss. So our call to action, rewriting the narrative. CVD anemia is underdiagnosed and is preventable. Early detection, gender-sensitive education, regional policies are essential. Empowering women, having these clinics is really important, and these type of discussions and this forum. I think social media has a huge impact. When I was going through researching to write up, do these slides, there was no mention of social media at all. We just recently submitted an abstract in endo, but not for cardiology, but it was about social media trends, just using, putting the word Mounjaro or Ozempic or so, and how it takes up. So I think social media has a huge impact on public awareness, and not only that, every day, each clinic, each patient comes in, they have some myth that they have to ask the doctora, it causes dementia, statins cause dementia. So every single patient comes into me, and now there's a recent publication that says it's not associated with that. So I sent them this, they already have my WhatsApp, and so on. So there's a lot of reluctance to start women on therapy, even recognize that they have dyslipidemia. So expand access to lipid-lowering agents, invest in MENA-specific research, and I think we should start screening earlier, maybe as they mentioned, post when they have children at that time, the child visit, they can be screened at that time or followed up. There's some references just to complete. When women's heart whispered signs of fatigue or worry, this is the time to listen and act early. Thank you. But I just wanted to